It is something, as I tell students who rotate with me all the time, it's fun to see technology. It's fun to see all the new things around us. But if you have a good rehab doctor, a good therapist, both PTOT, speech, and whatever other therapies who support you, a pair of parallel bars and a mat, that's really all you need. Everything else is secondary. And we'll see that as we go and we talk about each of the different things that we commonly use now. So, coming to, again, stroke and brain injury, right? Both of them are pretty much interrelated. So, other than some of the things that we do specifically, maybe for more of a traumatic brain injury, the way that we approach both patients with traumatic brain injuries and stroke, in this case, I will call non-traumatic brain injuries, is pretty much the same. We focus on our patient. We see what their impairments, limitations, and restrictions are. And then we look at their environmental and personal factors, right? I mean, the ICF framework is just so elegant for this that we can take pretty much any disease condition and put it into it and treat it appropriately. But especially for us physiatrists, I think it's just one of the most elegant things that we can put each of the diagnoses we treat into. So the timeline, that's something that we all probably want to know a little bit, right? We know what it is. Nowadays, the FAST acronym seems to be something which picks up everywhere. So 2 years ago, when I came to Ernakulam to see my parents, my mom, who is involved in the church community very actively, said, "You know what, Maya, you're home. You do all this stroke rehab and all these kind of different things. Would it be okay for you to give a talk to our church community?" And of course, I readily agreed. And we decided that the afternoon that I would be leaving home would be the perfect timing. As you know, most of the planes that fly out are at 3 a.m. in the morning. So I usually never leave home before midnight to go to the airport. So we scheduled our talk at that time. That was one of the days that the Cochin airport flooded. It was mid-August, and all the planes again did not take off from Cochin airport, and I had to travel to Trivandrum to get my flight. So my whole talk got canceled. The reason I'm saying this is I actually, that morning before I left, I had slides prepared for the talk, handouts prepared for people. I wrote out my talk for my non-medical father, who is a lawyer and a diplomat by training. And he and my mom is a chemist who has not worked for many years, either in the medical field, but both of them at some point of time had wanted to become doctors. So I wrote out my talk for them, and they decided that they will give the talk to the church community. And no one recorded this talk. It would have been very nice to see how it panned out. But they were telling me how much the community was able to give feedback. So one of the things I wanted them to use was the FAST acronym for showing that the face, arm, speech, and a timely manner of getting people to the hospital is so important when it comes to stroke. And I had little magnets for everyone who came for the talk that I had brought in, and handouts on it. And they were telling me how the priest in the church actually knew what the acronym stood for and supposedly told them that he would take over the talk from then onwards. As you can see, many times our leaders in the community do, and went on from there. The reason I say this is because it is very important. We all know that prevention is better than cure in anything. And especially in neurological problems, prevention becomes even more necessary than cure, because curing is not very easy, and it really depends on each person's brain, how they behave. So getting people to the hospital on time, giving them either TPA or whatever else is given to preempt whatever stroke which is occurring, or if you are in a facility to do clot retractions, which where I am right now, I'm in the middle, I'm smack in the middle of two um, stroke centers, so primary stroke centers where they have 24-hour either neuroradiology or neurosurgery available for clot retractions as well. So, that's where it becomes important. Just taking a few minutes, it people might be thinking this is not rehab, but in my mind, it's very much rehab. But one of the things that you will see, even with the most advanced facilities which are available and people who have reached in like minimal amount of time, it really depends on the person's brain what their deficits is going to be. So again, from a rehab perspective, once they're in the hospital, early mobilization, restoring of impairments in order to regain activities, right? The first weeks. So we try as much as possible to help the patient get back home. So especially here in the US, there's minimal amount of time that you get in acute rehab, which is 3 hours of therapy a day. And insurance companies nowadays, it can be anywhere from 2 weeks to 4 weeks maximum. If I get a patient to stay more than 4 weeks, that's a miracle. I say that's a good day, and my prayers are answered. And then, of course, the days to months where we follow these patients, ensure that they get the most amount out of the neurological recovery that they have made, and be able to translate it into functional recovery becomes very important. A lot of times patients are told that all their recovery is going to end pretty much in the first month or at the most within 6 months post stroke. But in my experience, and I'm sure in most of yours, there is no restriction to that time. It can be any time. So when we see our patients on a longitudinal basis, and there's some of my patients I now follow for because I moved from New York to India and then India back to New Jersey, maybe not for that long, but the 10 years that I've been in New Jersey, there are patients that I still follow. And I still see that they make progress depending on what we tell them to do. So maintaining the quality of life is very important. What all do we think are the various things that we do in rehab, right? Like I said, conventional intensive therapy is the baseline. A good therapist, a good mat, and parallel bars. Really, really important. Now, the rest of it that I have on this slide, whether it be mirror therapy using FES, magnetic stimulation, bimanual therapy, robotics, CIMT, body weight supported treadmill ambulation, or what is considered slightly more advanced and newer things, whether they're patients who've got stem cell therapy, the pharmacological treatments that we use. Jimmy, I think, was very interested in getting me to talk about pharmacology during this talk. Other neurorestorative treatments. So I do see patients, maybe from my cultural background of having grown up with Ayurveda, naturopathy, homeopathy, and everything around me. I am not one of those doctors who would tell a patient not to try something. As long as it's not harmful to the patient, as long as it's within their budget and they are not selling their house or preventing their children from going to school, I am quite open about allowing patients to do, therapies which are not considered mainstay along with what they do when they work with me. Also, especially neglected impairments like the mood disorders and things like that, sometimes which, people don't notice so much as they do notice the physical impairments, are very important to take care of. So in this kind of photograph busy slide, and you'll see that I do like pictures, and I think pictures talk a lot more than words do. There used to be a time in my life where I used to do presentations without a single word on the slides. It would be photographs and then what I could talk from that. I've changed a little as I've grown older because my memory fails me sometimes about the things that I want to talk about. So you'll probably see more words on the slides now than what I used to have. But you can see coming like in a clockwise direction from like 11 o'clock onwards, you see the exoskeletons being used in the therapy gym or the robotics or electrical stimulation on now coming down to 2 o'clock position or 1 o'clock position, we see virtual reality and robotics being used more, whether it's mirror therapy coming down to the bottom 6 o'clock position. Again, a combination of virtual reality, electronics, electrical stimulation. In the bottom, you do actually see this is the first generation of the arm robots. That was one of my patients when I was a trainee. Actually, that was the MITMANIS or the MIT first prototype of the hand robot. So the most, I would say, something that we as physiatrists talked about a lot from the time I know I was a resident, young attending, later on mid-career, and now also is how to use body weight supported treadmill ambulation. And this particular, so just to tell you right in the beginning, the studies that I've highlighted are actually the studies which were kind of like the sentinel studies for each of the different things I'm going to be talking about. So this was what people were awaiting. This was a multi-centered trial done all over in the US where they used body weight supported treadmill ambulation after stroke. And everybody's minds, there was no doubt about the fact that this really helped. But when the study findings came in, you can see that actually at the end of 1 year post stroke, no matter what kind of therapy that you used, pretty much the final achievements were all the same. Do we still, those of us in practice, still think that the body weight supported systems work well for selected patients? Absolutely, yes. So people who are more like up to looking at graphs than a lot of words. In these graphs, you can see that pretty much as the timeline goes in each of these graphs, whether the patients had severe impairment or moderate amount of impairment, at the end of 1 year, the final, measures came pretty much almost at the same level. So that was about body weight supported treadmill ambulation. So this is a few pictures just to show some of the earlier prototypes that we used. I'm sure in many of your hospitals in Kerala, you probably have body weight supported systems, whether they're the ones which are on, rails like this on top of your clinics or physical therapy gyms, or whether like the light gate. I'm using some commercial words during this, not that I have any particular leaning towards one or the other. The words which probably come up in my mouth is the ones that we use at one of our rehab centers. So I actually do acute rehab in 3 acute rehab hospitals in and around this area of New Jersey in the past 3 years, on and off at different places. So I've used different systems in different places, but this picture is very special to me because this was one of the prototypes we had developed at Montefiore. I had nothing to do with it other than being the one who did all the first testing on it. It was actually developed by the chairman of our department, Dr. Fast. And he worked very slowly with an engineering department of the University of Connecticut in putting this up. Um, Many people had commercially told him that they would buy it. At that point of time, there was no commercial system which was available, but he wanted his baby to be his, so he never sold it. By that time, somebody else had made a similar system and sold it commercially. So his never became a commercial system, but the principle is the same. You have oscillometers which show you where the position of the body is, whether the patient is midline, whether you're climbing up stairs using it, whether you're going up ramps when you're using the system so you can see yourself in the harness. This big machine over here was, like I said, the first prototype. Now machines are smaller and more silent than these are and don't require this amount of support. But we were able to use these specifically on our stroke patients. And most of all, what we saw was the confidence building effect of being in a harness. And patients, especially our elderly patients who had the fear of falling, which is very, very real. I have seen that fear of falling is probably one of the things which holds back a patient the most. Um, we were able to use this system to get them quicker back home. So, like I said, if we only got 4 weeks in the hospital, using the system while they were in our acute rehab unit, it was so much easier to get them home safely. We did not use it as an outpatient device for um, outpatient rehabilitation, so I can't tell you what the findings of that was. So I'm giving you some of the literature which shows what multi-center studies have shown, also personally bringing it close to my heart, where we have used the same systems and what our personal non-research outcomes were. So some of this will be biased because it's what you remember. And usually you remember most of your successes or very, very real failures. There's this whole chunk which it lies in between the successes and the failures that people tend to forget. So that's my disclaimer on some of the things that I'm talking about clinically. Coming to robot assisted, like I said, this picture on the top you see is one of the first generation robots, and that was, I recall, in the year 1999 when I was a first year resident in rehab. Um, and it was one of the rehab centers next to us had a connection with someone in MIT, and they decided to put the prototype over there. The article that I've highlighted for those who are reading along with me is one of the Sentinel articles, which was published in the New England Journal of Medicine, which talked about this particular robot assisted, stroke treatment that we were giving. So at this time, it was used mostly for chronic or subacute stroke, so post 6 months from when people had strokes. We did not use the robotic therapy in most of our acute care endeavors. Right now, you would see, and I probably would think, most of you do use some kind of a robotic equipment if you have access to it even in your acute. So I told you that I work in three acute stroke centers or acute rehab centers in the area. Two of them are like 60 bedded units, and one of them is a smaller unit within the hospital. And depending on, again, the budget which is available, each of them have some kind of a robotic assistive device which is used when we treat our stroke patients. So again, coming to the results of the study, you can see that the primary and secondary outcomes of this study pretty much showed that whether you looked at the Fugel-Maya score or you looked at the Wolf motor function test, um, or you used the stroke impact scale to look at what the outcomes were, they were pretty much the same in all of them. I mean, it showed an improvement in the Fugel-Meyer as well as the Wolf motor score, But when it came to the stroke impairment stroke impact score, it was pretty much the same. So just to tell you background over here, in the Wolf motor, the lower scores are better, and in the Fugl-Mayer, of course, the higher scores are better. And you're visually looking at it. So here I again have pulled a few articles from when they first were publishing this to also something which is much newer, where this particular one, Rehabilitation Robotics After a Stroke, the Lit Review in 2022. So a newer one. I'm not saying any of these articles have one better than the other. Pretty much when you read these articles, and trust me, I've read through quite a few of them to see what is the most relevant one to use during the stroke, during this talk. And they pretty much show the same thing. There is all early improvement. Patient satisfaction scores are higher when you use these devices. The number of times you can use it is also good. But depending on what kind of treatment people got at the end of 1 year, most of the scores look the same. So, what are other robotic therapies that we talk about or we see around us? It's always wonderful to see something great. And a lot of stroke rehab programs around this area have actually created technology rooms. None of the places that I work in have it, but I know that a few places around me do have it, places which have more budgets. So when patients and their families walk into the rehab, they get to see all this twinkling new technological equipment sitting around. Sometimes they will put up videos for people to see. Sometimes they have, people doing demonstrations to show how the technology works. But like you can see, the exoskeletons. So there are the exoskeletons, which are freestanding, which many of you have probably seen at your rehab exhibitions, as well as national or international rehab meetings that you have attended, as well as the ones which are more like solid, which are attached to frames like this, which can be used on multiple patients when they're in acute rehab itself, in their first time rehab. So most of these equipments, again, just like I said, the body weight supported treadmill ambulation or the body weight supported ambulatory systems that you can use over the ground. The fear of fall for patients is very much reduced. Patient satisfaction is higher when you use these. And we all know that the robots can do more repeated range of motion activities or the same repeated activities without fatigue that humans have. Like today morning, I tried to do an exercise, and when I read it, it was really easy. It just said 10 repetitions one way and 10 repetitions the other way, and do them 4 times. I said, oh my God, this is so easy. But when I tried to do it myself, and I know that I would get benefit from it, even with the knowledge that I knew that I would get benefit from it, when I was through set number 2, I was done. I didn't want to do anymore. So fatigue, both on the patient's part, if someone does not push them to do it, or fatigue on the therapist's part, who have to do the same repeated motion over and over and over again, is what robotics takes away. So definitely it does have its role. But like I said, it is not, it's not the bedrock of rehab. Constraint induced movement therapies, right? CIMT was the rage when it came out. Again, like I tell you, I used to do a lot of presentations with just pictures which would remind me what to say. So if you notice, the primary author of this CIMT trial is Dr. Wolf. So my slide actually had the picture of a wolf howling at the moon. And I was giving a stroke talk as an audition talk the first year that I was in my fellowship training, and I was looking for a job at Emory. So just a hilarious anecdote over here. I was talking about CIMT because it was all the rage at that time. This was 2003 and 2004. That in that time frame must have been three. Um, and I put up this picture of the wolf howling at the moon and started talking about CIMT without realizing that Dr. Wolf actually worked at Emory and was in the audience. So I could see people looking at each other, smiling and nudging each other, and I was wondering what it was. But the man was so kind and gentle enough to come at the end of the talk and say, "Hello, I'm Dr. Wolf. I was the wolf who was howling at the moon in your slide." And needless to say, he was such a gentleman. Took me actually, it was not supposed to be part of my day's tour, but showed me his entire lab setup where he was doing, at that time, preparing the Excite trial, and went over every little detail of it and was very, very, very kind for someone who had actually put up a picture of a wolf. But needless to say, I did not get the job at Emory. Somebody else must have felt that, okay, today if she puts up the picture of a wolf, I wonder what she will put up tomorrow. But as you can see in the Excite trial, yes, this was after the first trial showed promise and people made very great benefits. They did this trial across the US in multiple academic institutions. And it did show at 3 to 9 months, CIMT produced statistically significant, clinically relevant improvements in arm function that persisted for at least 1 year. Later on, if you come down, you look at the different articles that I put on CIMT, and probably like when you look at a literature review, CIMT has the most number of probably articles of all of stroke rehab. But I was just surprised to see another article from Dr. Wolf and company over here with him as the senior author later on, where in the Lancet, where they talked about all the different studies which had been done. And basically, their conclusion was none of the studies showed anything significant um, um, when compared to similarly done studies. They again said they were not sure what the mechanism was, whether it was the forced paradigm that worked or the unlearning of the learned disuse. I mean, these are things that I will never forget, you know. So, students out here, remember if you ever get to talk to a pioneer in the field, remember that is something that will never get erased from your memory. I mean, someone can wake me up from sleep and ask me, what were the principles behind CIMT? And I can say the forced use paradigm and the learned disuse of the limb. So, things like this you won't forget. Remember, all things we might not learn directly, we learn from the people who have gone forward before us, and we get the most out of it. So, trainees, remember that your professors have many, 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 many more years of experience than you have. So learn from it. So even if you're a trainee only for 1 month, remember that you're getting benefits of years of their training and their experience. So as you might have noticed when they introduced me, one of my pet things is education. And I have decided at this point in my life, I actually like teaching patients, family members, and medical students because they are such a captive audience to anything that you want to teach. And they're like sponges, they absorb everything that you want to teach. And every time I talk about teaching students, I get super, super excited. So that's why the, little bit of extra talk to the students and the trainees in between. Okay, so transcranial stimulation, direct direct current stimulation. Now, this article, Pablo Chelnik and I, we completed our residency pretty much at the same time, two different institutions, but we used to meet together all the time at the national meetings. And when I trained for the program for academic leadership at the AAP, it was a 3-year program of just 5 people selected from around the country to do the training every year. Pablo and I were in one cohort. So he, did one of these, again, one of the first proper randomized controlled trials using this. It's not that Pablo, discovered this. I mean, there are many people who have used electrical stimulation before that. The very word physical medicine and rehabilitation comes from the fact that we have used all kinds of physical methods to treat patients over the years during the course of how our specialty developed. But it's a very elegant crossover study where they used all kinds of different things. And it was a true randomized controlled trial, which showed what transcranial direct electrical stimulation can do. After that, now, I mean, all these devices are probably even available online. All you need, as shown in the picture over here, is a 9-volt battery and 2 electrodes. One is used as the anode and the other is the cathode. And in most of the studies, and you can see that I've highlighted one of the studies over here, which basically is an open, access journal, I think, where they talk about a beginner's guide to design and implementation of this. So how to do this is available online. And actually, I was reading a book recently. It was a general book, not a medical book, about education in the US and how people, ace at their exams or how you can ace at competitive exams. And one of the things that this particular author did was actually use transcranial direct electrical stimulation and wore it overnight on his head. And the next day went and wrote the LSAT. That's the exam that you get into law school for. And he showed that he was able to get like a 10-point advancement on that particular test he did. So why I'm saying this is it's basically a very easy thing to do for even someone who's not, medically trained or an engineer. It's a very simple setup. But because it's been a very simple setup, we have not seen a lot of this being used on a commercial basis because I guess people did not realize, or people realized very early that they're not going to make a lot of money making these devices because anyone can make them. So even though I was very excited in the early 2000s, hoping to see that people will be using this more, and every single one of my stroke patients would be sleeping in the night with direct current applied to their temples or their frontal areas of the brain. I'm sorry to say, none of the places that I work is this an approved device that anyone uses. But if you look at the studies about this particular device and what it can do for both cognition as well as motor function, it looks like, it is the next best thing after sliced bread. Moving from direct current stimulation to electrical stimulation in general. Now, we all use this in our practices, right? I've just put a bunch of pictures there to show all the different ways that we use it. The most elegant one, I think, is really for the shoulder subluxation and the shoulder pain that we see in our acute strokes, right? You can have implanted devices like the ones which are shown here. These were video clippings. I've decided not to do any video clips on this because usually they all fail. But basically, all it shows is how these can contract the muscle and hold the shoulder better in place. Whether we use that or we're using electrical stimulation to dorsiflex the foot and the commercial available cuffs, which we can use along with them, or just the plain handheld electrodes. So in all the rehab centers that I work, we basically have handheld devices that the therapists put on the muscle where they want to put, and they use it manually as they walk. Some of them, they use the commercial devices as well. This one over here is a little more elegant, where they're showing how to train the paretic side using the non-paretic limbs. So we have the glove connected over there, and depending on the muscle movements which happen in the non-paretic side, we can actually move the same muscles on the paretic side by giving electrical stimulation and having the patient visualize it. More than anything, this is a brain visualization technique. I tell my patients, I tell the therapists all the time that all these things that we use is adjunct to what we're already doing for the patient. We're asking our patients to visualize in their brain, to retrain the brain to use the parts which were not used before, to form new pathways in the brain to have function. Okay, now we have the computer-brain interfaces, which is one step above the electrical stimulation, where we did direct electrical stimulation in the muscles of the body. Here, we're actually using the brain centers, and from there, trying to send signals down into the motor function of the body. Again, theoretically very elegant. You can see, and why I call this from bench to bedside is most of our bench studies have been translated to bedside, but not to every bedside. I wanted to remind that. Some places are able to do it where they have research protocols, but most places around, even here in the US, these are not translated as much as we would have wanted to have seen them by this time. So that's why articles, you can see articles from like 10 to 15 years ago when, people had multi-centered studies to now in 22, 23, 24, we are still stuck almost at the same level and playing around with the little mouse and not able to get it completely into humans. But it's exciting. Don't get me wrong, I'm not pouring ice water on top of anything that you're seeing. I'm just saying that nothing is fast, everything takes its time. So again, this is using the brain-computer interface. These were videos to show that when the brain was stimulated during the computer interface, that people were able to grab objects. I mean, why do we do all of this? It's to improve function, right? And to improve function, to feed yourself, which is one of the most important things. Every day when I go and do bedside rounds with my stroke patients, I always make them go hand to mouth, because that's one of your most primitive impulses, to feed yourself to survive. Okay, I'm not going through much of the music, just saying that those are all elegant stuff which is out there. We all play music in the gyms when we train our patients, using bimanual training, making the good arm work, the not so good arm, we don't say the bad arm, but the one which is not working so well, is again a very elegant theory. um, I'm speeding up a little bit more so that I can get at least 10 minutes to talk about the pharmacological stuff. So mirror therapies, we know that it was an Indian who first, you know, uh, brought the concept in. We use it a lot in amputee training. We can also use it in stroke training. We also use mirrors a lot to get people to have their body straight. Midline body is usually the best indicator of how a patient will progress in their therapy. So this is, I have a whole bunch of studies, actually Cochrane database reviews of all the things that we talked about, which are reviews from the time it was a bench study to at the bedsides across the world, wherever the studies come from. And basically all the results are pretty much similar, which show that there's definite improvement depending on the patient you're using it on. Um, and also at the end of a year or so, more or less, most of the things come together. And why are the results so variable? Because everyone's brain is different. And I say you can look at the same MRIs of 5 different people and walk into the room, and there is no way for you to tell which MRI belonged to which person, because they can all behave very, very differently. So it all depends on how your brain does. So coming to pharmacotherapy, and we can use the same principles both in brain injury and our strokes that behave like brain injury, right? Why do we say brain injury differently? Because the moment we say our brain injured patient, we're thinking of someone who has attention deficit, who's irritable, who's confused, who has no sleep wake cycle. The poor nurses in the night are awake with them the whole night because they think it's daytime. They're trying to wander around the place. There's a lot of agitation. Even the other day on our floor, we had someone who physically harmed a nurse's aide who was working with him. So all these things become making it want us to be able to control these as much as possible, giving them some kind of a chemical, right? We all went to medical school to train as doctors to be able to dispense some kind of medication to someone and make them better. Hey, just because we became physiatrists, that doesn't mean that we're going to be using electrical stimulation and all those things. We still want to use medications that we can take a prescription pad out and write a prescription for. So, what's the basic principle? Anything you use, you start low and you go slow with the dosing. Remember that your injured brain is very sensitive to side effects. A side effect which would not be seen in one patient might be seen in another. And your ultimate goal is that you want them off those medications. You don't want someone on a medication lifelong. And also, in this era of polypharmacy, be stingy with what you give them. You want to probably use a drug which can be used for two different things while the patient is there. So, say, if you're using something for agitation, you can use gabapentin, which would which is shown to help with both agitation and with neuropathic pain that the patient might have. Plus, it can cause drowsiness. So if you dose them in the night a little more than you dose them during the daytime, you can hopefully change the sleep wake cycles. So remember, use drugs which can be used for more than one cause. I had a teacher whose few principles that I've used over here. He was a neurologist who taught us brain injury at Kessler. And, he always used to say, when you give a patient Haldol, you're actually killing a small kitten, because I think he liked kittens. But that's why my cat with the drugs sits on the top to remind that of. So basically, the things that we want to avoid is haloperidol, clonidine, benzodiazepines, phenobarbital phenytoin when we're using it for seizures. We can use other drugs like carmazepine, valproate for better control. Um, I do something in some of my older patients. I do stop using statins when they come, just because we know that they can potentially cause muscle weakness. So we take them off the cholesterol lowering agents. It can also work badly against cognition. I blame all my memory deficits on the fact that I'm on Lipitor for over 20 years now. Um, GI agents like metoclopramide or some of the other antiemetics, which can cause motor dysfunction, anticholinergics in general, you want to avoid. What are the stimulants that you use? So I just put a table up where you can see dextroamphetamine, methylphenidate, and pamela, of which I actually use methylphenidate quite a lot. It says in a range from 10 to 80 milligrams per day that you can use it. I usually stick to around 20 to 30 milligrams, and I do get benefits depending on the patients that you choose to use it on. So it's basically for attention, concentration control, and they can do much better in therapies with that. Also for the sleep wake cycles, and you come to, I haven't put it up there, but modafinil is a drug that many people like using when they're especially looking at attention concentration as well as sleep wake cycles. I do use a lot of dopaminergic agents, both in my TBI patients as well as my acquired brain injury patients, which are non-traumatic as well, depending what signs and symptoms the patient shows. So if they're showing akinesia, if they are showing a lot of tremor right in the beginning, they are showing more basic ganglia sort of like features. I do use levodopa carbidopa combinations. I use amantadine. I recently had a young man who came to us after going to another rehab, being sent home, and his mother said he was walking in rehab. He came home, he can't walk at all. He falls at least 80 times a day when he tries to walk. Came to us. I first put him on amantadine. He showed a little bit of improvement at 100 milligrams twice daily. Still was showing features of Parkinson's like features. He was a drug overdose with cardiac arrest, which caused anoxic brain injury. So started him on a low dose Cinemet or levodopa carbidopa combination. He now comes back to see me. He doesn't need his wheelchair any longer. He walks with a cane, but much better. So we do see good results with those. I use bromocriptine a little bit with some of my aphasic patients. I have not seen great differences, but it's still drugs that you can use. I'm not talking about concussion. I left it up there because concussion by itself is a whole hour-long talk. But I didn't want you to think that I am not thinking about concussion when we're talking about traumatic brain injuries and what we can do for it. And this is an area that we can do a lot, if not anything, just education-wise, because people don't realize what concussions can cause. Now, with more of media blitz about it, maybe you see more of the common man talking about it, but it's still something that we physiatrists know a lot more about and can educate our patients and their families. I wanted to talk about this just 30 seconds because this is a rehab institute which is quite near us. And most of you probably have used Sarah Cucurullo's board review handbook in the recent years. It all came out after I graduated. But I mean, this is a study on stroke survivors that Sarah instituted on an NIH grant, where they used the principles of cardiac rehab to stroke patients. And this was their pilot study. What it showed, decreased mortality, increased cardiovascular performance. Of course, they're using the same principles as cardiac rehab, and of course reduced 22% of all cost readmissions. Now you must wonder why that's there, right? Because in the US, readmissions to the hospital is one of the things that all insurance companies monitor, and especially Medicare, which controls the healthcare of everyone over the age of 65, in which who strokes occur more commonly. One of their main things that they follow all over the country is readmissions to hospital. So if you say that something reduces readmissions by 22%, there is a chance that Medicare will cover that for all patients. Right now, this kind of an exercise program is not covered by Medicare. This was done only on a grant. They're doing a multi-center study now. Okay, I am not talking about stem cells because it's still really a bench kind of study. I know that there are many places, not just in India, but all over the country where they offer stem cells. The actual studies which are done in humans are just so small and not, they show promise very much, but we still have to wait. So over the past 30 years, there's been considerable research. 130 single therapies demonstrated efficacy in animal models, but late phase 2, phase 3 studies, at least in TBI, this slide is based on TBI, have not shown the same benefits that we saw that rats, cats, and monkeys had. So we'll still wait. There are possibilities out there. AI is a thing which is looming in, and you can see over here, very patient-centered, patient-tailored therapy methods is what we are going to be talking about as time goes forward. Like we said, every brain is different, so we would need to know which each brain needs. So, we can cure sometimes, relieve often, and comfort always, which is one thing that I learned. We can either think that we can get up from the chair and be walking, or we can be very comfortable in our chair and be happy but functional at the same time. This actually is today morning's Google cartoon. So I thought that was so appropriate this morning to have that. And with that, I come to an end. I am so sorry. I have timed it over just 1 hour. I hope we have some time for questions.
Yeah. So thank you very much for your wonderful presentation, because I have covered, I think it has covered almost all recent concepts in the management of stroke as well as traumatic brain injury. And I have written a lot about it. Anyway, at the outset, I would like to say the slides were very good, super, and your voice also crystal clear, right from the beginning to the end. And a lot of eye-opening sessions were there for me as well, because the format of the slides were like presenting lot of pictures are there, and I think the residents also should note how the PPT presentation should be designed, and the format of studies, the study, the details, the results and conclusions. I think that format is very super. And her talk began with the ICF framework, and then awareness of rehab, going through the medical, then the clot retraction, then the overviews of therapies, then we us know about the body weight support treadmill training, and then regarding the robotics, the Fuggelmeyer and the Wolf Motors pace score that improved, but the stroke impact score not much improved. That was a message she has given. And the importance of robotics is that there is no fatigue. Yes, exactly. Either from the patient part or from the therapist part. So invariably, the robotics is going to score invariably. Then about the CAMT, and she has presented a lot of studies regarding CAMT. And then regarding the transcranial stimulation, the direct current stimulation that is combined with PNS, peripheral nerve stimulation, is going to be true results. Then implantable electrical stimulation devices. I think that is, I haven't seen that in our place. And the ideas of all these therapies is to retrain the unused brain pathway. Then some words about BCI, the brain computer interface, where she is stressing on the hand-to-mouth movement, because that is a fundamental of human existence, to feed themselves. Then about music therapy, I think a lot of questions may be there in the music therapy, and then bimanual therapy, mirror therapy, then virtual rehab. Even our centers are having that virtual rehab. But towards that, she has made a very wonderful statement. If, in spite of all these therapies, it may not work for everyone, because everyone's brain is different. That is very eye-opening session in fact. Then about pharmacotherapy. In pharmacotherapy, please note that start low and go slow. I particularly like that statement. With a low dose, you start and you slowly step up. And gabapentin, the commonest one we are using for sleep-wake cycles, it can be used as a new piece of information for me. And also the medicines to be avoided in acute brain injury. Then stimulants used. And then about stem cells, a word. She said, it is rightly said, it is in the bench level only. And about National Concussion Day. Anyway, madam, thank you very much for a very veritable experience that you have given. I think there are lot of questions are there in the chat box. I can see 5, and I think I can read that. Madam, can I ask the questions?
Sure, go ahead.
Yeah, how long to continue anti-epileptics after traumatic brain injury? And your drug of choice as an anti-epileptic in traumatic brain.
I mean, we still follow the protocol of if there has been no seizures after the first 48 hours, that you give it only for 7 days and you stop after that. And it's very funny. It depends on where the patients come to you from rehab. You'll see all kinds of different things. Sometimes I see patients like after a year coming to me and they're still on an anti-seizure medication and they have no memory of ever having seizures. So we usually taper it and stop it. I go down on doses very quickly when I have them on inpatient. So we said start low and go slow, right? But when they're on the inpatient floor, you can do things much quicker. Just like you can go up on doses quicker, you can come down on doses quicker because you get to see them every day. And I usually stop seizure medications if they are on and the patient has no seizures reported. But the general consensus is after a traumatic brain injury, 7 days and then stop.
Thank you. Shall I read the next question? How long after stroke can we take a patient for transcranial magnetic stimulation and TDCS? How long after stroke?
So I don't know the correct answer for that. I don't think there is any correct answer for that. As long as you think that your patient is stable on your floor, clinically, if you can see that it's not something that is going to make a difference, I guess you can use it, but don't take me on that. That's not a scientific answer. But I did not see anything in any of the papers that I read about any particular time frame.
Okay. I do want to ask you a question on the MERCY, the mechanical embolus removal in cerebral ischemia. What are your personal
Uh-huh.
experience with that?
Um, so there have been patients that, I can read from charts. So I no longer do consults in the acute care hospital. My knowledge of this is more from what the patients and families tell me when they come to acute rehab and what I read off their chart. But I have seen tremendous successful clot retractions, even those done after sometimes many hours after the stroke has occurred, where the patient was completely flaccid, no movement on that side, and they come to us with at least workable motor function on the side. With speech, not that much of benefit. Once your speech center is affected, I have, at least in my experience, seen people coming back, but their speech hasn't returned that much. And then, of course, I have seen people who've had their clots retracted within like an hour's time because we actually have a mobile stroke unit in our area. So the ambulance will come do the CAT scan in the ambulance. So before they reach the hospital itself, you know whether they've had a bleed or not. They usually receive TPA within the ambulance even before they reach the hospital because they have tele-visit with the neurologist who's on call. And people who have reached in got MRIs immediately, seen what the stroke burden is, and done clot retractions within like 2 hours of the stroke and have had absolutely no return.
Okay, thank you. Another question. Can you enlighten us on which medicines to use when a stroke survivor is very reluctant or apathetic for physiotherapy sessions?
So there are people who use SSRIs all the time. I do use SSRIs in patients, again, starting on low dose, going up, because again, I do see if it's someone with spasticity, SSRIs can worsen that. So you don't want to use it at that time, but we do use them. Modafinil is something that people use all the time because they feel that the apathy is from the fact that they don't have arousal. So you can use that to improve arousal. I use Ritalin a lot, or methylphenidate, because it's short acting, and when they're with you, it's something that you can see very easily whether it's effective or not.
Okay, thank you. The next question is on gut-brain axis. Can you enlighten us something about the gut-brain axis, about how the gut microbiome could change and possibly affect the neuroregeneration in stroke patients?
I know everything is based on microbiome. My husband works for J&J and on their medtech side, and I know many times that they've talked about having relationship with companies which work on microbiomes, but I am not an expert on that, and I do not know the answer. And remember,
Okay,
guys, especially for trainees, it's perfectly okay to say I don't know when you don't know something.
okay, yeah. what are the new and the effective advances that can be tried in patients with aphasia and the poor attention and cognition in traumatic brain injury syndrome regarding their communication?
So, I mean, we use intensive speech therapy methods where we use electrical stimulation, sometimes just for the throat muscles, thinking that it might be something happening over there. We do use, but if someone cannot still communicate, so I have 3 people on my service right now who cannot communicate at all. And one person we think might work with, like, communication devices. That we can use, but we always use the baseline of using just pictures, communication boards with patients until they can work on something which is higher level. Then, of course, people who, as they go higher level, there are computer-based, treatment things that we do use.
Uh, is there any role for bromocriptine in aphasia?
So I think I mentioned it during my talk. I have used bromocriptine. Again, anecdotal, this was how I was trained. When I was trained, everyone said use bromocriptine. In my personal experience, I have not had good success with it.
Okay. And about the memantine donepezil, do you have any experience?
Um, um, I can't say that I've seen, we use it, both the drugs we use kind of on off. Usually also when patients' families bring it up when we're having discussions. Dramatic changes? No, I haven't seen any. This is personal experience. I'm not talking about review studies.
One question regarding the safety of SSRIs in hemorrhagic stroke.
I don't know, but I do use SSRIs. And hemorrhagic stroke, especially, I mean, I don't know what aspect you're talking about, but I see hemorrhagic strokes usually develop tone earlier, and spasticity earlier. And of course, like I said, I am a little reluctant to use SSRIs when there's tone developing already, especially when the tone is not appropriate tone. Some
And
tone
when
is
you,
good, some is not.
yeah, very good. Any experience with the vagus nerve stimulation and the anti-exciting?
No, I don't, and I didn't look into it during this talk.
Okay. Then another question is on autonomic dysfunctions in traumatic brain injury, and how do you manage like tachycardia or increased blood pressure or excessive
So I
diaphragm?
use propranolol a lot because, like we said, right, a drug which can control 2 different things. So whether it's to be used for agitation, behavioral issues, as well as the tachycardia. So my drug to go over there usually is propranolol, and it's a time-tested drug. I
Yeah.
am more conservative in things that I do. I do a lot of things, but I also do it with things that we know much more about.
And which beta blocker will you think about if the patient is having simultaneous bronchial asthma?
It all depends. So I have chronic severe asthma from childhood, very,
Yeah.
very bad. I'm on biologics. Just sharing that with you, but I'm also on 120 milligrams of propranolol daily because it
Oh,
helps with my familial tremor.
okay. Thank you. Thank you for the information. And another question is on how do you manage patients having shoulder subluxation, traumatic brain injury, and CV?
So we usually make sure that we position them in bed with appropriate amount of pillows. During therapies, I showed you the e-stim. We do a lot of e-stim with shoulder subluxation and shoulder hand syndrome patients. And it's usually very effective. We do a lot of kinesiotaping. Our therapists, both PTs and OTs, do taping. I personally know how to tape shoulders. Um, all those methods basically for shoulder sublux. And we do use, when we're walking, the slings which hold, you know, commercially they're called, one of them is called Give More sling. We don't use the slings which go like this, but the ones which hold in a little bit when we're ambulating patients.
And antihypertensive causes pseudo-intestinal obstruction in stroke and traumatic brain injury. What's your experience?
I have no idea. I think that's a good way to stop by saying, I have no idea, because that makes sure that we will go back and read about this.
Yeah, definitely. That is the right answer. One question is regarding post-stroke spasticity management. What is the recent advances or procedures or the drugs or neurolysis being practiced? Post-stroke spasticity.
Oh, that's again, there's a particular reason why I didn't put it into the talk, because if we talk about spasticity, that's again a whole hour talk. But I mean, botulinum toxins are the most commonly used. I use phenol and alcohol a lot with my patients. I mean, cryo is being used now, using other injections, especially in contractures, surgical methods. It just goes on and on.
Yeah. Okay, ma'am. I think it is enough for today because you have presented
Thank you
extensively.
so much.
If the questions are being used like that, you all talking like. Thank you very much for the excellent presentation and response to questions. Thank you. Thanks a lot.
എനിക്ക് കേരളത്തിൽ വന്ന് പോയ പോലെ ഉണ്ട് നിങ്ങളുടെ കൂടെയൊക്കെ നിന്ന് ഈ ടോക്ക് തന്നിട്ട്. I cannot actually, for the life of me, even though my Malayalam is good, I don't think I can ever give a talk completely in Malayalam, whether it be on a medical subject.
Okay. Anyway, thanks.
Madam, Maya Madam, it was a really wonderful feast for us. Thank you very much. And we again expecting this type of talk in future also. Now I invite our Dr. Jimmy Jones to express vote of thanks.
Thank you, sir. First of all, thank you, Maya Madam, for your taking time out of your busy schedule. You have a flight to catch, and I don't think we should, continue any longer.
Thank you, Jimmy. Send the vote of thanks by letter.
Thank you so much, ma'am. Thank you.
Thank you. I'm signing off, okay? Because I really need to catch this plane.
Okay. Thank you, ma'am.
Okay,
thank you.
Thank you.
Thank you so much.
Okay, വളരെ വണ്ടർഫുൾ ആയിട്ടുള്ള ഒരു പ്രസന്റേഷൻ ആയിരുന്നല്ലേ ഇന്നത്തെ. ഒത്തിരി നമുക്ക് ഒരു 500 ആൾക്കാർക്ക് അക്കോമഡേറ്റ് ചെയ്യാൻ പറ്റുമെന്ന് വെച്ചിട്ടാണ് നമ്മൾ നാഷണൽ സൂം മീറ്റിംഗ് എടുത്തത്. പക്ഷേ ഇറ്റ് വാസ് എ മിസ്റ്റേക്ക്.
100
പറ്റുള്ളൂ. എന്തായാലും നെക്സ്റ്റ് ടൈം ഐ തിങ്ക് വി ക്യാൻ പർച്ചേസ് സൂം ഫോർ 500.
Sir, next month in the academic meeting in മുമ്പ് നമുക്ക് കേരള ചാപ്റ്റർ പർച്ചേസ് ചെയ്യാമെങ്കിലേ
അത് നമുക്ക് ഉറപ്പായിട്ട് ചെയ്യാം.